Good morning, everybody. May or may not be on everyone's radar, but this week is Diversity Week for the college. So we are very, lucky to have a lot of interesting talks going on throughout the week, including our grand round. So it's our pleasure to have Dr. Daniels with us this morning to discuss healthcare disparities and diversity and inclusion in our community through his talk on implicit bias and neurosurgical training. Dr. Daniels is a pediatric neurosurgeon by training who completed his MD at UCLA, residency at Albert Einstein, and fellowship at CHOP. He currently practices at Hovnanian Children's Hospital, as well as many other affiliates in New Jersey, and has started his own really interesting practice out there with a very specific focus, which I'll let him speak about. With respect to initiatives in diversity and inclusion, Dr. Daniels is very active on the board of directors of Mentoring in Medicine, which is how we became connected through Lynn Holden in our work in primes. And has made it his mission to inspire new generations of physicians across all backgrounds through outreach and education and mentorship. We look forward to hearing his perspectives on methods of increasing inclusion and supporting a diverse workforce to better serve all of our patients. So with that, Dr. Daniels, I turn it over to you.
Thank you. That has to be one of the best introductions I've ever received. Thank you very much. I appreciate it. So listen, first of all, I'd like to tell everyone, thank you for having me. My name is Lawrence Daniels. I'm a pediatric neurosurgeon here in New Jersey, medical director of pediatric neurosurgery at Jersey Shore University Medical Center. I'm currently sitting here in my laboratory right now. I have an independent laboratory, a biotech company, a technology company, 2 medical practices. So very busy, very robust practice, but also a lot of experience, especially dealing with implicit bias. So, the talk of today is going to be implicit bias in neurosurgical residency. I have no conflicts of interest to disclose. So as an overview, we're going to start off by talking about something called social identity theory, which is the theory of social psychology for which the concept of implicit bias was introduced and falls under. We'll also talk about some of the evidence surrounding implicit bias, the evidence in terms of the evidence of the theory of social identity theory and implicit bias within it, but also some of the evidence as well in the literature in terms of implicit bias in residency training. And then we'll talk about power dynamics. These dynamics of social identity theory have to be seen and looked at in the context of power dynamics, and oftentimes power dynamic differentials. And then we'll talk about solutions, right? What are some of the things that we can do as individuals to address some of the blind spots that we might all have, and make a more equitable training environment. And then after that, what I'm going to do, because there's really not much literature on implicit bias as it goes in neurosurgical training, I'm just going to talk about my experience in training. And, to do so, we would have already gone through a lot of the more technical information on social identity theory and implicit bias. So, my understanding is we'll be in a safe space, and I'll just let you guys know, what I've been through before neurosurgical residency, during neurosurgical residency, and after neurosurgical residency, to kind of, give us an idea of what some individuals are experiencing. Right. So social identity theory. So it predicts, it's a theory in social psychology that predicts interaction between and amongst groups. And a lot of this interaction is based upon group status or perceived group status, and the stability and legitimacy in this perceived group status. So you oftentimes have an in-group and an out-group, and the in-group individual is where this perspective is coming from, and it's between this interaction with in-groups and out-groups, and the ideas of status of the out-group versus the in-group, the legitimacy of the status, the stability of the status, and the ease at which someone from the out-group can be incorporated into the in-group. These are all the dynamics, right, that lead to some of the things that we see in interaction between these groups. And this is essentially an overview of the social identity theory. Now, so what's important is there is a tendency for people in the in-group to favor other individuals in that in-group. And in addition to that, it's kind of like the opposite side of the coin, that there is a tendency for people who are in the out-group from your in-group for you to then punish those individuals or place burdens on those individuals. So defining implicit bias therefore is precognitive or pre-reflexive characteristic traits that are bestowed upon people that are in out groups by other individuals from a separate in group. Now, some of the evidence that's out there, I'm going to present evidence in general for implicit bias. So this was a study that was conducted in 1988, and it's a study on parents' perceptions of their children's math abilities. And in the study, it was noted that the parents of young women attributed their math abilities less than the abilities of their sons or their male counterparts. And the reason why I chose this study to elucidate is that oftentimes implicit biases are projected upon us, right? But then there was another study, similar topic, where it took the implicit biases that young women had on themselves, right, in their abilities in math, and how it then made them withdraw from the topic of math in general in fields in STEM and science in general. And this was important because it illustrates our implicit biases acting upon us, right? So in addition to that, recently, over the past few years, there have been a significant amount of work in publications done on implicit biases in surgical training, specifically gender biases. And this is a study about microaggressions. Microaggressions are, you can look at implicit biases as the attitude and microaggressions as the behaviors that extend from the attitudes. So this is a study on microaggressions and implicit biases in surgical training. And, the essence of it is that, there were 1,600 respondents, 72 respondents reported microaggressions, but only 7% reported it to the graduate medical offices, graduate medical education officers, or program directors. And out of those 7% of individuals that reported it to these administrative bodies, 30% said they experienced retaliation as a result of it. Specifically in the field of neurosurgery, since around 2018, there's been some work, some observational studies on the women in medicine and inequities in gender in medicine. And actually this year, there was an article written about African-American women or Black women in neurosurgery, in the intersectionality between being an African-American person or a Black person and being a woman. So I believe that this is something that we are beginning to discuss and begin to embark on. And I think that's really important, but I also think that we have a long way to go. Now, the fact of the matter is this: when we usually and typically discuss social identity theory, we're usually talking about one identity group versus another identity group. But in reality, each individual comprises of multiple different identities, right? Sometimes my identity as a man is the identity that's most salient in a context of a situation. Sometimes it's my identity as a neurosurgeon, right? When I'm talking to PICU doctors about, management, or, arguing with trauma doctors about whether to put an ICP monitor in or not. At times it could be my identity as a Californian, my identity as a Warriors fan, right? We all come to the table with multiple different identities, and these multiple different identities are interacting with multiple different perceived identities from other individuals. And at any given moment, we can all be either on the receiving end of identity biases or on the providing end of identity biases, right? So this is a Dr. Henry Jaffiel, and he's one of the main and early contributors of the theory of social identity theory, right? He's a Polish Jew born 1919 and died in 1982. And it was through his experience during the Holocaust and him witnessing, what he described as ordinary people participating in horrific acts that made him begin to look at things a little bit differently than what was the prevailing theory on why individuals exhibited bigoted behavior and prejudiced attitudes. At the time, the prevailing theory was that there were personality traits, extreme personality traits, like the authoritarian personality trait that would make an individual, essentially exhibit as a bigot or exhibit prejudiced attitude and discriminatory behavior towards a population of people. right? But, you know, as a person, as a Jew who fought for France and was captured and became a prisoner of war, and as an individual who lost, you know, countless numbers of friends and family members in the Holocaust, he began to wrap his mind around how could people who didn't necessarily find themselves on the extreme of personality traits begin to do some of these extreme and contribute to some of these extreme and horrific things. And his contributions to social identity theory were that self-categorization, our ability to put ourselves in groups, strongly influenced our prejudice that we exhibited towards other individuals. But in addition to that, he also had contradictions. He was always hesitant to apply these concepts of social identity theory to gender. In addition to that, you know, he was accused of, and there was some evidence of, him exhibiting biases towards females, right? In a form of inappropriate behavior towards some of the female that worked around him, and not excluding women and working into his laboratory. And I pull this slide up to show the importance of the fact that some of these things that we're dealing with are human traits, right? And no one has ownership of what it means to either experience someone else's implicit bias, right? Or no one is exempt from exhibiting their own implicit biases on other people, right? And it's important to keep that in mind. I'll give a personal example of that during this talk. So what we are going to do, we're going to, step away from the theoretical that gets really, really technical when you get into the weeds, and we're going to use quote unquote implicit bias as it's really being used a lot today in the media around discussions of discrimination, systemic bigotry, and injustice, right? So this is a definition that I just Googled, and I picked one of the first things that popped up in Google, and it's unconscious attitudes and stereotypes in the criminal justice system, school setting, workplace, and healthcare system. Now, all four of these things we are going to discuss. We're going to discuss implicit bias in the criminal justice system, in the school setting. And when we talk about neurosurgical training, the workplace and the healthcare system happens to be the same place. So we can kill two birds with one stone. Now, before we get into that, another very, very important thing to think about is these group interactions often always occur in the context of power differentials. Now, as mentioned before, I did my training in the Bronx. I did my training at Montefiore Medical Center, and I trained with Dr. Eugene Flam towards the later end of his career. And the reason why I picked this cartoon, because it reminds me of a time where I had to talk to Dr. Flam about one of his patients in the operating room. It was taking a long time to wake up. And, for those who know, Dr. Flam, can have a fiery attitude and temperament. And, this is the way it feels sometimes as a resident to go in and speak to this person, which oftentimes we would laugh about, but that, has your destiny in his hands and can fire you at any moment, depending on how he feels. And so, especially when we're talking about residency training, it's important to realize the power dynamics that are at play, right? And how these power dynamics influence, these implicit biases, and how these implicit biases, make us as individuals feel. Now, this is a screenshot that I took from yesterday. And it's a screenshot of my phone of an article from CNN. And there's a politician, and the politician is denying racism in the United States and says that America is not a racist country. Now, the headlines, as they often are, a little bit unfair, because he does acknowledge the fact that things are not perfect in the United States, and that, we definitely need to change certain things. But I bring this up because oftentimes when you get into a circle and you begin to challenge one's perception or one's implicit biases, it is natural for people to get defensive, right? And in doing so, and often part of the problem that I have with social identity theory is it doesn't acknowledge the fact that in these power systems, all human beings are being exposed to implicit biases, whether you're the powerful, whether you're not the powerful. And as a result of that, when we're in a position of power and we feel like something's being taken for us, we react defensively like other human beings. But what it often does is it creates blinders in us. And so one thing that I think is important to realize is that when we are in a situation of power and we're considering power dynamics and there's a power differential, we have to ask ourselves, if the goal of all of this is to create a more equal society, and specifically when we're talking about microaggressions and when we're talking about micro analysis of these situations, if the goal in neurosurgical residency is to create a more equal, right, environment, a scenario around training, then we have to look at our own power in certain instances as attendings. And sometimes we have to be willing to give up some of that power for the sake of balancing the scales to give our residents an opportunity to, at minimum, express themselves and give us an opportunity to see whether there's something that we can do to be more helpful in this process of training. And this speaks to how much do we truly want an equal society? And specifically with the topic at hand, how important do you think it is for there to be diversity in neurosurgery? How important is it for there to be female neurosurgeons, Muslim neurosurgeons, African-American Muslim neurosurgeons, neurosurgeons with business degrees, right? I firmly believe these things are important because these individuals have insight into the patients that come to us. And as long as we're taking care of a diverse population of patients, I think it's important to have diverse perspectives, right? So I think, you know, in our own ways, we have to decide how important is this to us. And if it is important to us, then when we find ourselves in these situations where we feel like we're in a more powerful position than other individuals, oftentimes, you know, it's for us to take it on a chin to allow there to be more equality so that some of the other individuals with less power can express themselves and communicate to us. And, you know, I was finding the darndest time to try to figure out in this power dynamics, what power that residents had. So somebody can, you know, send me a text or afterwards, you know, I want to open it up for discussion, but, you know, unfortunately, residents don't really have much power in the power dynamics of residency training. All right, now, so reducing implicit bias. You know, there are companies and consultants that can come into an organization and do things like inclusion training or cultural competency courses and training to try to allow us to identify some of our own biases and then be able to operate with the mindfulness that these biases exist. You know, something else that can be done is, you know, mindfulness and meditation. Now, you know, I was hesitant to spend much time on this when discussing with neurosurgeons, but I remember there was a neurosurgeon in my training. He was a South Asian neurosurgeon, and I had a very, very long night of work, and we were doing a CP angle tumor, and I was shuffling under the microscope, and I jousted the microscope, and it threw him off in the middle of the case. And I was a junior resident, so I didn't understand how important this was, but almost for the rest of the case, he just kept perseverating over how he was in the zone, and oh my gosh, you know, he has to start over again, and he was in a groove. And so then, he's the most polite attending that I ever worked with. And then afterwards, he realizes that he was kind of putting me through it in a very passive aggressive way, but nevertheless, he was putting me through it. And he had a discussion with me. He said, you know, sometimes when I'm operating, it's like I'm meditating. And then I get into this zone, right? And, you know, that jostling took me out of the zone, and I was working to get back into that zone. And I think as neurosurgeons, we do this, right? You know, we're in a trauma activation, you know, all hell's breaking loose, and we are putting ourselves in a place where we need to be in order to accomplish what we need to accomplish technically for this patient. And I can see myself doing that at times where I begin to block out what I can block out and begin to put myself in a zone. And I believe that if it's this type of mindfulness that I think all of us practice in some shape, form, or fashion, that if we are beginning to deal with the conflict between a resident, you know, in a program, if we approach those conflicts with that same type of mindfulness, I think it might help reduce the stress of the situation, reduce the cognitive load, and might allow us to be able to pierce into or gather some insight into some of the biases that we might be armed with and that we might need to disarm in dealing with some of those conflicts. The last two are education, right? Understanding implicit bias and how it impacts the way we treat one another. And that's part of the reason why we went through what we went through earlier before I begin to tell you about my personal story, is because being aware that these things exist, being aware that, we're all impacted from it, is important. And it's important in allowing us to then put it at the forefront of our minds and allow it to be a tool that we can use and arm ourselves with when we're dealing with conflicts, intergroup conflicts. And then adjust perspective. This is easy to say, and it's common sense, but putting yourself in someone else's shoes. But in order to put yourself in someone else's shoes, and this is the problem that I have with Lindsey Graham's comment, is you have to have experienced what they've experienced. And oftentimes we are talking about experiences in these different groups that other groups don't have the luxury of experiencing. But we're all human beings. And with a little bit of empathy and with a little bit of patience, you can listen to another person and you can get an idea, of what their struggles are, what their perceptions are, what their biases are, what biases are being pushed upon them, right? And I think it makes for a better opportunity for us to deal with some of the complexities of these intergroup interactions. Now, so now that we've done that, right, and we've all become experts to a certain extent on social identity theory and the implicit bias that affects all of us, we're going to talk about me. That we don't have any studies in neurosurgery where we in detail analyze the experiences of outgroups, right, such as, minority groups in the United States, or other outgroups such as nonconformist or even innovators, right? We really don't have these studies to give us information and impact on how these individuals are affected through the residency training. So what I'm going to do is I'm going to offer up my experience, right? And at this point, if anybody has any questions and concerns, you can just go ahead. I want this to be a discussion. You can go ahead and unmute yourself and just ask me, right? But my hope is that through me discussing some of these very personal things, it can be an icebreaker for your program. And if we have any residents or any attendings at that might then have some things like this that they would like to discuss with their program, but then let me be the first person to do it. And I can do it safely because you guys don't really control me, right? You guys can't fire or hire me, right? And so for me, it's easy to do. But the hope is that it becomes a icebreaker and allows conversations like this to happen. Because I believe ultimately, the real solution is to be able to talk about these things freely, to be able to comfortably share one's experience in the world, and also share how someone's experiencing their residency. So we're going to talk about things that happened to me before my residency, which are important because then they created, the perspective that I went into residency with, including my own implicit biases. We're going to talk about some things that occurred to me during residency and how I handled it. And then we're going to talk about, after residency. And part of the reason why we're having this discussion, like was mentioned earlier, I'm on the board of a nonprofit organization called Mentoring in Medicine. And I was asked if I would give this presentation. And at the time, professionally, I was going through a lot, and I had, developed this alliance of people who essentially had my back and would come and support me anytime that I would have these microaggressions. And the more successful you become, the more is at stake. And it seems like the more aggressive some of these things are. But some of my allies, for the life of me, I couldn't give them a perspective. I couldn't let them understand that from my view, some of these things represented microaggressions. And I was saying to myself, it's all over the news how, Black men are being killed by police, unarmed Black men are getting killed by police officers, at an alarming rate. But no one takes though, and we understand that some of these happen to do with the fact that police officers are more frightful of Black men than other people because of certain biases that we have. And this is, white police officers, Black police officers, Latino police officers. And I was saying to myself, why is it so difficult for people to apply those same concepts to profession, into medicine, right? I mean, the studies are there, right? There are studies of, implicit bias in neurosurgery as it pertains to patients, right? The studies are there, but it's difficult for us to make these pivots because so few people have these experiences. And Black people, right, Black men, we don't feel comfortable sharing these experiences, right? Because of the penalty of sharing these experiences socially, right? And we'll get into some of that. So before residency. So remember, we talked about, the four areas where these implicit biases become really important in society: criminal justice, education, work, and healthcare, right? So let's start off with criminal justice. Now, for the life of me, what I decided to do is just rattle off some of my experiences. These are not all of my experiences. And after a while, it sounds like redundant, at least it sounds redundant to me. But it's important because all of these experiences, some form or fashion, shape I perceive the world perceiving me, right? So I grew up in West Oakland, which is an underserved area, and I got a scholarship to go to one of the top high schools in the country, a high school called Athenian. I grew up in the Bay Area, and it was in Danville, California, in an area called Black Hawk, which is one of the wealthiest areas in the Bay Area. And so at one time, myself and two of my friends, one of my friends, his father, very wealthy man, owned one of the largest commercial real estate companies in the United States. He's an African-American male. Another friend of mine's mother was an ambassador for a West African country. Another friend of mine who was a Pakistani male. His father owned a slew of pharmaceutical companies in Silicon Valley, or pharmacies in Silicon Valley, shall I say. And then it was myself and a friend of mine named Q from East Oakland, right? And both of us came from underserved areas, and we commuted to the school and we got a scholarship. So we're sitting in Black Hawk, and we caught the shuttle from the school about 2 miles off campus to the shopping area, Black Hawk Plaza. And we're all sitting there, congregating, waiting for the shuttle to pick us up and waiting for some of our other classmates to come out of the store and meet us. And while we're there, this police officer sees us, and he sees these, 4 men of color, right, in this very wealthy area, and it's something just doesn't matter for him. So, obviously he's profiling us. So he approaches us, and the first thing he asks us for is our ID. Now, by this time, I'm around 15, we're coming of age, we're hitting our growth spurts, we're getting a little bit of bass in our voice, we're developing muscle, we're all athletes. So, I am, used to dealing with police officers in West Oakland, which are far more aggressive. They're a completely different breed. So for me, this is not a big deal. So I'm getting ready to pull out my ID and comply. But my friend, whose father, is the commercial real estate developer, tells the officer, no, like, why are you asking for our IDs? And the officer begins to get testy, and he's like, hey, look, what are you guys doing here? Right. And my friend told him, was like, we're students at, at Athenian, we're here with the school bus. He's like, well, then show me your ID. And my friend was like, no, I'm not going to show you your ID. And as a matter of fact, what I want you to do is I want you to give me your badge number. Right. And the police officer gives him his badge number, and then he just walks away. And then my friend tells me, he's like, hey, listen, and you were talking about it, and he's upset about it. And me and my friend from Oakland were like, all he asked for was our ID. That's the least I can do. Right. And my friend was like, no, you don't have to do that. You need to know your rights. My father has hired attorneys, right? My father has attorneys on retainer. My father hires attorneys to counsel us, right? And teach me, and my brothers how to handle ourselves under these circumstances, right? And, that was useful for me. Now, the reason why that's important, there was another time in East Oakland, right? A different variety of police officers where this is maybe 4 or 5 months later, again, one of my friends from Oakland, and then another my friends, Q, who went to school with me, who was in that other setting, we would go to a party, and a under 18 party at a all girls college in East Oakland. And at the end of the party goes on later than what the school wants it to. So the school calls the police, and then so a group of police officers begin to enter campus while everyone's leaving from the party. So me and my 3 friends are leaving from the party, and the police officer, probably inadvertently, bumps up against me. But mind you, I'm 15 years old, right? And I weigh like 135 pounds. And so when he bumps me, it tosses me. And my friend Q turns around and he's like, what's the meaning of that? Like, why did you do that? He wants to have a conversation with a police officer. Now, mind you, my other friend from West Oakland, where I grew up, has had enough experience with police officers to know that that's not what you want to do under those circumstances. So he turns around and he's getting ready to, run, right? You could see it. And so what I do is I turn around and I take my friend Q and I turn him around and I push him forward. I'm like, come on, man, let's just go. But by that time, the police officers had turned around to engage with us, right? And as the police officers turned around to engage with us, and I take my friend Antar and I push him forward, the police officer then grabs me by the collar and tosses me about 6 feet in front of us. And as I stumble and try not to fall, I look at my friend Eric, or my friend, whatever, my friend E, and he's getting ready to take off, right? And as soon as he takes off, there's probable cause, right? They have an opportunity to grab us, slam us to the ground. My other friend Q turns around and he's even more indignant at how we were being treated. So I grab him again, push him forward. And at this time, the police officer takes his baton out of his buckle and he raises it. And as he does this, I remember the encounter that we had with the police officer in Blackhawk. And I remember what my other friend told me. And so I turn around and I say, give me your badge number. And as soon as I do that, the two other officers turn around and they walk away. But this other officer increases his pace towards me. So I say it again, what's your badge number? And I will never forget those numbers, 452. And he turns around and he walks away, right? Now, after this encounter, I go home and I have a conversation with my mother, and I am beside myself. And at this point, you know, between the time of getting home and thinking about this scenario, I'm telling myself, listen, there's the police officers and myself, we're mortal enemies. There's no way I can get along with the police officers. I don't trust them, right? I don't ever want to call them, right? And I'm furious about this. And my mother talks to me. She says, listen, Lawrence, it's more complicated than that, right? You have every right to feel like you were feeling, but you also have to understand that you were raised in Oakland. You've already lost a lot of friends and a lot of family members, right, to the violence in Oakland. And there's also been a lot of police officers killed with the violence in Oakland. And what they're doing now is they're shipping police officers, they're recruiting police officers from Texas to come into Oakland. And under those circumstances, that police officer was probably scared for his life and needed to get back home to his family. So I'm not saying that what the police officer did to you is right. I'm just trying to tell you it's more complicated than that, right? And she was right. And so I begin to develop nuance, right, about the power dynamics associated with my interaction with police officers. Then, and all of these things happen between the age of 15, 16, maybe 17, right? Between 14 and 16. So another time, so we had moved to Berkeley. And I'm driving in my sister's car. I'm just leaving my house. I'm driving in my sister's car. I stop at a stop sign. I see a police officer behind me. I am acutely aware of how police officers interact with me now, right? And so at this point, I make sure I come to an abrupt stop. I make sure my car stops for a good second, and then I take off and make a right at the corner. And as soon as I make the right, the police officer hits his lights. And once he hits his lights, he pulls me over. And when he pulls me over, he comes to the car and he's like, you know, I stopped you because you didn't stop at the stop sign. And I'm like, I absolutely know that I stopped at the stop sign. I recognize you being behind me. I know I stopped at the stop sign. That's not the reason why you're pulling me over. So he's like, you know, get out the car. I got out the car. He handcuffs me and then he puts me in the back of the cop car. Now, what I remember most vividly about this entire scenario is all my neighbors passing by, seeing me in the back of the police car, right? And fortunately, one of the people who saw me in the back of the police car was my sister's friend. And so she raced to the house, she got my sister, and then my sister drove out to the police officer. Now, apparently, there was something going on with my sister's plates in her car. I'm not quite sure. I think she got a different set of plates. I don't know what it was, but he was running the plates in the car and he couldn't match the plates in the car. And he was getting ready to arrest me and take me to jail. But my sister came, she showed him the other plates in the glove compartment. They kind of had a laugh about it. And then he lets me out the car. And I overhear him talking to my sister. My sister's like, why did you handcuff him in the back of the car? And the police officer says, well, he looked like he was fast, right? And I didn't want him to run. So I get home, and what was important about this entire scenario was that my sisters had a chuckle about it. And they were like, well, wait a minute, is this your first time, you know, being treated like this by police officers? It was like, because every Black man I know has had this experience. And for them, it was almost like a rite of passage. It was almost like a coming of age, right? And, you know, these things, you know, again, begin to shape how I viewed the world's view of me, right? Now, fast forward to medical school. I think I'm in my 3rd year of medical school. I'm doing my clinical rotations. I just finished a rotation in OB-GYN. And I am coming home from call. I was in a rotation of OB-GYN. I'm coming home from call, and I live in Santa Monica at the time. I live 3 blocks away from the beach. I mean, I'm paying, hand over fist for this apartment. But for me, it's worth it because I can run to the beach in the morning. It's so nice. It's so beautiful. You can smell the ocean from my apartment, right? And so I go home, drop off all of my stuff. I used to leave my door unlocked. So I go home, close my door, and I proceed to walk 3 blocks to the burrito store on Main Street to get a burrito and then come back home and study. I have my white coat on still. I'm in scrubs. I have my ID hanging out my coat. And I walk through the parking area of my apartment, and I get to the next street. And when I get to the next street, there's a police officer there. And the police officer is like, hey, do you live around here? And I'm like, yeah, I live around here. I live in the apartment. And I pointed towards my apartment. He was like, oh, well, let me see your ID. And I was like, sure. So I showed him my ID. And he looks at my ID, and my ID has my Berkeley address on it. So, he sighs, he's like, man, your ID is not from around here. And I'm like, well, I'm a medical student. I like, look at me. I show him my badge. And, we have a tendency to move. So I kept my permanent address back home, right? But I mean, I live, literally in the apartment that I'm pointing to right there. And he's like, oh, yeah, there's a problem. He's like, would you mind showing me your apartment? No, that wasn't it. So he's going back and forth, and he's deciding whether he should do more with me. And so I reluctantly and almost jokingly, I'm saying, hey, listen, do you want me to show you my apartment? He's like, yeah, could you do that? That would really be helpful if you could do that. I'm like, fine. So we walk together another block, right, back to my apartment. And I get to my apartment and I open the door. And I'm like, see? And he's like, well, I really would have liked to see you put your key in your door and open your door. And I give him this look, like my mouth drops. I'm like, are you kidding me? So I walk him into my apartment. I show him a picture of myself on my entertainment center. And then he's like, oh, I'm so sorry, man. It's just, someone's called. Someone complained that someone was accosting their car. And, we just really needed to check. Now, I've been through this before. The examples that I just gave you guys, those are not all the examples and run-ins that I've had with police. Those are the probably more PG-13 run-ins that I've had with police. Those are the least controversial, right? For me to make my point. And like I told you, police officers in Oakland are very different than police officers in Black Hawk or in Berkeley or in Santa Monica. So I wasn't afraid. This wasn't a big deal. This is kind of what I just had to deal with. And I was like, you know what, that's fine, man. Be safe, right? I wish you the best of luck. Be safe. I'm going to go ahead and just continue to do what I was doing with my day. And he's like, well, let me offer you a ride. I'm like, no, I don't want to ride in a cop car, right? Like he doesn't know this, but I have experiences in cop cars. I don't want to ride in a cop car. What I want to do is I want to enjoy the summer breeze, and I want to walk to the area to get my burrito. So he's like, okay. So he leaves in the opposite direction, and I go back to the very place that I was where he stopped me. And there's a female police officer, and she's like, hey, shines the light on me. She's like, what's your name? I'm like, I tell her my name, and she's like, she approaches me, and she said, put your hand on the wall. She puts my hand on a little gate, and she begins to pat me down. And by this time, I mean, I'm losing it, right? And I'm like, what are you doing, man? I'm sitting here. I have a white coat on. I'm a doctor. I'm a future neurosurgeon. Now, mind you, I hadn't applied for residency yet. I'm a future neurosurgeon. I'm throwing all these things at her. I'm probably one of the most educated people in the area. I'm taking all these things as a defense mechanism to try to convince them that I'm not who you think I am, right? And she stops. She asks for my ID. I give her my ID. And while she's looking at my ID, there's a cop car pulls up, and a cop car gestures her to come over. So she takes my ID to the cop car. And then when she looks at my ID, she talks to the person in the cop car, and she says, hey, you come here. And at this point, I'm like, no, I don't. What is going on? I don't want to come here. This is ridiculous. She's like, hey, you come here. Now, mind you, I glance over, and there are 2 other little kids, 2 skateboarder kids riding the skateboard, and they're huddled up, and they're terrified, right? And they're looking at me, like I'm terrorizing the neighborhood. And it's the same feeling I got when I was sitting in the back of the police car in Berkeley, and people were driving by looking at me like I did something wrong, like I was guilty, right? So I reluctantly approached the car, and in the car, it's the same police officer that pulled me over initially. And he's like, "Hey man, I'm sorry. I can see you're getting frustrated. You know, I feel really, really bad about this. How about you get in the car and you let me take you to where you're going?" And I was like, "I don't want you to, right? I mean, there's a reason why I live in this area. There's a reason why I live so close to the beach. I mean, this is a part of me decompressing from what I've experienced over the last 24 hours training at this hospital." I was like, "I really just want to walk." He says, "Well, listen, the reason why I want you to get in the car is because I can see you're getting frustrated. And we have police officers at every other block between here and the burrito place that you're going to. And I am concerned about what might happen if you keep getting stopped by police officers. So if you wouldn't mind, can I drive you to the burrito shop?" And so I did. I got in the car. I let him drive me to the burrito shop. It was the, quietest, most awkward, 2 minutes. And after he left, I wished him good luck. I told him to be careful, right? I understood that he had a dangerous job, and, he wished me the same. I ate at the burrito shop. I hung out there for about an hour just to make sure that I wasn't going to run into any issues walking back home. And when I got to the hospital the next day, I talked to some other surgeons, some other African-American surgeons, who some lived in Beverly Hills, some lived in Bel Air. And I asked them about this. And I'm like, "What's up with this?" And they're like, "Yeah, something you just have to get used to, right? If you want to live in a nice area, it's something you have to get used to." And, me being the person I am, I called my landlord the next week and I told him I was moving, right? I didn't want to live in an area like that where I didn't belong, right? Where I wasn't wanted. Now, academia. So when I was in high school, like I told you, I went to an outstanding high school, and I was accused of cheating by one of my biology professors. And so they, I'm in the school with the dean, I'm in the school with the associate dean, and I'm in the school in the room with the biology professor, and they're talking to me about this exam I took, and I don't know what the proof was, what the evidence was, but I knew I didn't cheat, right? And so they're going back and forth. I mean, they're interrogating me for like, it had to be about an hour, 45 minutes about this test. And they can't get me to admit that I cheated. And so at the end of the conversation, the professor says, "Well, Lawrence, it's my understanding you want to be a doctor, right? You want to go to medical school." And I was like, "Yeah." He's like, "Well, you got to work hard to go to medical school. You have to get good grades to go to medical school." And I'm like, "All right, what's the point, And, he kind of just let it sit in the air. And then after that, and I think that the associate dean and the dean, felt bad about what he said, but you could tell he was extremely frustrated. And so we kind of left, and that was that. Now, mind you, that was over 25 years ago. But what I took from that was, what was there about me that made you so convinced that I was the type of person that thought that I was going to be able to cheat my way into medical school, right? Like, how preposterous was that, right? When I was in undergraduate, I have 2 degrees. I have a degree in business administration and a degree in psychology, right? And so while I was an undergraduate, I went to orientation, and during orientation, they saw that I was going to get an undergraduate degree in business. And at USC, you have to apply to the business school. You don't get automatically accepted. So they arranged my classes first in that. So then when I started, I realized that I was going to be behind track to get to medical school. So I went to the College of Letters, Arts, and Science, and I talked to the counselor there who was assigned to me about making certain changes to my schedule. And I had outlined my schedule, including summer classes and sometimes taking 24 units in order for me to get back on track for medical school. And after I told him all this stuff, he turns to me, he said, "Listen, man, forget medical school." He's like, medical school is really, really difficult, and it's going to be harder for you, because of your schedule. So I said, "Hey, listen, don't worry about it. I've already worked it out. I know how I can work it out." And he looks at me, he says, "You know what? It takes immaculate grades to get into medical school. So if I was you, I'd probably just focus on business." And I left his office saying to myself, like, listen, this guy's supposed to have my best interest in mind. Now I'm in college, right? I'm swimming with the big boys. All my life, I wanted to be a neurosurgeon. And is this the universe telling me that I'm not capable, right? Have I reached my limit, right? And so, what I did was I made an adjustment. I said, if the university is telling me that I'm not good enough to be a neurosurgeon, if I'm not good enough to go to medical school, the university is going to have to prove it to me. And I overstudied, I overprepared. And it was a great lesson because I set the curve in every class that semester, right? So now, So coming into residency with this perception, right? These things have built my implicit biases to the outside world, to this out group that was more privileged, more powerful, that was constantly telling me that I wasn't capable. I had built up defense mechanisms based upon my perception of this group that I took in with me into residency. Now, my friend Q also went to an Ivy League school and then went to one of the top business schools in the country and then got a job for Merrill Lynch. And so we both came to New York at the same time and we decided to live together and we would discuss these things. And some of the things we discussed was a concept amongst the African-American community called the Black tax, about how you have to work twice as hard, right? And how you will experience twice as much criticism, right? And so I'm going into residency armed with these concepts. And so the question became, well, what's your strategy going to be? Q had to develop a strategy because he was in finance. His job was to manage other people's monies. He had to convince other individuals to give them their money. In order to do that, he had to conform. But for me, this concept of conforming was paramount to the concept, was synonymous to the concept of wearing the mask, right? This is a poem by a poet named Lawrence Parr Dunbar, born in 1872, born to two formerly enslaved parents in Kentucky. And he's one of the first influential African-American artists on American literature. And he has a poem called Wear the Mask. And this is a concept that, you know, a lot of African-Americans take with us, right? We wear the mask that grins and lies. It hides our cheeks and shades our eyes. This debt we pay to human guile. With torn and bleeding hearts we smile, and mouth with a myriad of subtleties. So my concept was, why should I wear the mask? What's the point of diversity if I can't share my background and my experience with my residency? How are my counterparts going to ever understand their African-American patients if I'm not presenting my authentic self? In addition to that, my residency training was in the Bronx, which is one of the most diverse and one of the most underserved counties in the United States. I felt I was coming to serve my people. So I wanted to bring to my residency my experiences intact. Well, I don't know about all residencies, but my residency was like an exercise in conformity, right? I remember senior residents used to tell me things like, neurosurgery is like having to be a machine, right? Or an internship, the thought was, you need to learn these things so well, so they're like a reflex. We don't necessarily need you thinking outside the box, reinventing the wheel. These things have been done for generations and generations before you, and the details have been worked out. So at your level, all we want you to do is do what you are told, right? So you can imagine with my philosophy of coming in and bringing my rare experience to the residency, you know, the proverbial fan was hit, right? I remember engaging in debates with one of my chief residents about Eurocentrism and the Native American culture's, you know, deep reverence for nature. And, you know, him talking about the importance and impact of Western civilization and how no other civilization has contributed to the benefits of mankind. And he brought up the Industrial Revolution. And then I brought up global warming and the fact that if we're able to incorporate some of the philosophies of our Native American brothers and sisters about, you know, a symbiosis with the ecology, then maybe we would not have created such technologies with the unintended consequences of essentially destroying, you know, nature. I remember there were all these microaggressions that were exhibited on patients, and I would take it upon myself to step up and discuss these with some of my residents. Mind you, I'm a junior resident, right? This is shaking the power structure. The one that I remember most was a chief resident who was towards the end of the day, it was a late day, he was tired, and we were receiving a consult from Barnabas Medical Center in the South Bronx. And I remember him being frustrated and saying, man, I hate those patients coming from that place. And I was like, what do you mean those patients? What do you mean those people? And we start talking back and forth. And I mean, we got into a heated conversation. It was an argument. And I ended up in the chairman's office, right? And I'm trying to voice my concern, but it was something that my chairman, you know, he didn't understand, right? And what he was more concerned about was me breaking the ranks, right? Was me getting into almost what led to a physical altercation with my chief resident, over something that I thought was egregious, right? So what ultimately ended up happening is I, in a way, ended up confirming my own implicit bias about my residency and about the society that I was entering to train. I am not casting any aspersions on anyone in my residency program. I am not saying that anyone in my residency program, was racist or exhibiting racist attitudes or prejudiced behavior towards me. I have my opinion about that, but I can't prove that. What I'm here to talk about is how my biases, how my perception influenced the way that I navigated through residency. But all these things led up to a situation where in the concept of social identity theory, I begin to create a greater and greater rift between myself and this in-group. One of my residents, a Jewish resident, pulled me aside and he said, dude, what's wrong with you? I was having a conversation with one of my attendings, and I was very lackadaisical. We was very friendly. We were joking around with each other, and I hang up the phone. And he's like, dude, what are you talking about? Don't joke with him. He's not your friend. He's the man. He's like, you know who the man is. He's like, do I have to explain the man to you? He's like, these attendings are not your friends. There's this club. They have this really, really interesting club, and they haven't decided whether they want to let you in or not yet. So until they do, you have to walk this fine line. You have to be careful. Don't give them any ammunition. And it's that concept of this in-group's perception of one's ability to enter into their in-group. And what I was doing by essentially participating in the ostracization of myself in my residency program is I was creating that distance and I was creating barriers into entering that in-group. Now, so I had to seek advice. And some of the advice I got, I called another neurosurgeon that I trained with, that I spent some time with at Cedars-Sinai. Dr. Keith Black was one of my mentors. And I remember having to talk about some of the research I was doing at Cedars-Sinai and defend some of the work and the results I was getting. And after going through that process, Dr. Black stands up and he says, okay, Dr. Daniels, now you're learning the ABCs of neurosurgery. And I just kind of like laugh and, pretend like I know what he's talking about. But he insists before he leaves, it's like, do you know what the ABCs of neurosurgery are? And I was like, no. He was like, assess, blame, and criticize. And he just walks out the room, right? And so I reach back to that program and I talk to another younger neurosurgeon and I tell him about what I'm going through. And I said, hey man, listen, I don't understand what's going on. And he's like, one, this is neurosurgery and this is how neurosurgery is, right? Neurosurgery is a very critical field, but in a sense you kind of have to be, because neurosurgeons are going to have to decide whether they're going to allow certain individuals to do things that can have terrible consequences to patients. So my advice to you is you have to be twice as good, work twice as hard, and you have to cover yourself. You have to work in a manner that's beyond reproach. Now, I talked to another friend of mine who I went to high school with, who was mixed with Jewish and Black, and he constantly would talk about having to live in both of these different worlds. And he told me, he said, listen, when you go to work, just pretend like you're white, right? I mean, this was wearing the mask on steroids. Like, I want you to physically go in there and pretend as if you are walking onto the stage in a play and you're a white person. Pretend like you're white, behave like you're white. Now, I didn't take that advice, but I understood what he was saying, because the issue was a matter of conformity, right? And how would I conform? So as oftentimes happened under these circumstances, there's kind of like a trial of such. And there was one attending who just really had it out for me. So behind my back, he's building a case against me. And they have this meeting that I didn't know about. And the neurosurgeons kind of like are talking about me and they're trying to discuss whether they want to kick me out the program or not. And two of my mentors and attendings get up and they walk out in protest. And then the secretary of my chairman approaches me and she says, Lawrence, they just had a meeting about you. This individual is trying to build a case against you. You're going to have to present this situation in M&M, and I want you to be prepared. But I need you to know something. You have to fight. I don't know why this is happening to you, right? And I've never seen this happen before, but you have to fight. You have to learn how to fight for yourself. So ultimately, what I began to do, I had one attendant call me, and every time he would call me on the pager, he would accuse me of not having answered 4 or 5 pages before that. Well, I got really, really good with the operators in the hospital. And at times, we would get, during the busiest times of the day, our pager would go off every minute and 45 seconds, right? On average, it would go off every 5 minutes, during a 24-hour period. But they would keep a log of every time we were called. And what I got in the habit of doing is every time I would get a call, I would write on the back of my list of patients, and I would write the time, and then I would write when I responded and who I responded to, right? And I remember doing this one M&M that this one attending tried to bring up where we were operating and the bovie went off automatically. And the patient got burned on their skin, and it was a superficial skin burn. It, wasn't of any consequences, but he tried to turn it into, evidence that my technique was extremely poor and that I was dangerous to patients. So I had to present this during M&M. So I had to get affidavits for the people who are in the operating room who witnessed the machine go off uncontrolled. I had to take the number of the machine. I had to take the report from the engineering department in the hospital that described the malfunction and short circuit that the machine experienced. And I had to present all of this during M&Ms. And ultimately what happened was, the program inspected me as a resident and they lift up the hood. And what they saw is a fine-tuned machine, because I had received advice that I had to approach my residency like this. And I think it was the best thing for me, because once everyone saw this and once everyone also saw what I was going through, it was and in addition to that, what they also saw was they saw the fact that I gave patients my cell phone number, that we had a young man who was diagnosed with a glioblastoma multiforme at 72, a young Dominican guy, and his parents didn't want to tell him his diagnosis. So after his biopsy, he would come back to the hospital time and time again. He would be confused about why he was there. So I gave the family and the pediatricians my cell phone number and my pager. And whenever he would come in the hospital, they would call me and I would meet him in the hospital to play games with him or to play or to watch baseball with him, things of that nature. What they saw, they did see my contributions from someone coming from a community like that, and they appreciated it. And as a result of that, the rest of my residency was triumphant. Now, it doesn't mean that the residency was not without some shortfalls, right? And some of those shortfalls was another African-American resident that matriculated into our program. And he was an outstanding resident, and I was excited for him to be there. And as I was turning the corner on my residency, and as I was getting clout, and I was getting more responsibility and more power, as I was transitioning to a senior resident and going through my research year, I had a conversation with him about some of the things that I thought that he might expect. Now, I didn't want to take my experience and taint him with my experience. So I wanted to leave it open for him to have his own experience, but I wanted him to reach out to me if he started experiencing some of these things. And I left it up to him to reach out to me. By the time I finished my research year and I came back, he had already sat down, had a conversation with the chairman about the fact that he was going to leave the program. He was offered an opportunity to leave, right? And they gave it to him. And one of the stories he told me that convinced him that he needed to leave was the fact that he was doing an LP on a patient on the floor. And after he did the LP on that patient on the floor, the patient got up and the patient walked, and the patient had a DVT and a massive pulmonary embolism, and the patient died. And jokingly, the residents were telling him about, oh, you killed the patient, you killed the patient. Now this, along with all the other things that I know he was experiencing, tipped him overboard. And I always felt like I should have been closer to him. I should have created an environment for him to talk about these things while he was going through them, because I think there was a great potential neurosurgeon to contribute to neurosurgery that we lost, right? In addition to that, I had another resident that didn't make it through the program, and he was an Orthodox Jewish resident. And I remember talking to him one day, and this is at the time where I was picking my fellowships, and he was interested in pediatric neurosurgery. And he talked to me about these different places. So I'm like, this is a great residency here. This is a great residency here. And he told me, he's like, listen, I don't think I can go to this place. And I'm like, why not? I think you'll be great. He's like, because I need to be somewhere where my people are, right? I need to be somewhere where I have community. And I understood him, right? I understood the risk because of historically what his people had been through. I understood the risk associated with him being somewhere that was completely foreign. Right? But it also shed light on some of the other things and struggles he was going through in a residency, trying to conform, right? Trying to be this machine, that prototypical resident, right? Which his experience and background would make him very difficult for him to do. But his background was extremely important, especially to the type of patients that he was going to be taking care of in his community. And we lost that in neurosurgery. And the last thing is there was a female resident, a South Asian female resident. And, she was very disgruntled. And I thought that I was very cognizant of these things as a chief resident, because some of the things that I went through, because of the type of program that I wanted to be responsible for in terms of my responsibility to train residents. But she would just never listen to me, right? She would just never do what I told her to do. And it went on to a point to where her and her co-resident were really struggling because her co-resident was having to pick up the pace. So we got into it, right? And we both triggered one another's implicit biases, or we were both triggered by what we thought were the other's implicit biases. And part of her assumption was, well, I had an implicit bias with her because she was a female, and I was treating her this way because she was a female. And that triggered me because as an African-American, and after all the things I went to, I'm like, how dare you say that I would do something like that to you? But in hindsight, right, I didn't know what else she was going through. I had discussions with, other attendings about how to approach the situation. And, some of our own implicit biases were exposed at that time. One of the things that was said was like, well, she's from India and there's a caste system in India, and maybe she's used to the caste system. And as a result of that, she doesn't feel like she needs to take orders from you, right? But I didn't know her culture. I didn't know specifically where she came from, her religion, her background, her caste, right? And that was an assumption that we were making, right? But what I should have done is I should have sat down with her, and I should have created an environment to give her space to tell me what was going on with her. What I didn't at the time wasn't familiar with the microaggressions that women experience that men don't experience. And these microaggressions then paint their experience. And she might have been dealing with that. And we didn't create a space for her, right? So in conclusion, was my residency successful? I believe so, right? I wouldn't change anything about my residency because it's prepared me for the world, right? Oftentimes I'll talk to residents, and I remember in residency saying like, oh my God, I'm working so hard. Oh my God, there's so much pressure. Like, I can't wait to get done with this. And as attendings would joke and they'd be like, yeah, okay, well, wait till you get done. And the fact of the matter is everything gets a little bit harder after residency. In dealing with these issues of intergroup interactions, right, in the realm of social identity theory and implicit bias and explicit biases, right? Yeah, they become more intense. And the more successful I become, the more visible I become, the more I have to deal with these things, right? And a reminder, we all have implicit biases and we all experience implicit biases. And no one has ownership of, what it means to be, experience someone implicit biases. And then what's the purpose of all this? Well, the purpose is that if we truly believe in the power of diversity, and we truly believe that it's beneficial for us as neurosurgeons to have different perspectives in our field to usher the future of our field, but then sometimes we're going to have to give up a little something, right? I should have given up a little power to that female resident because she couldn't hurt me. I had already earned my stripes, right? There was nothing she was going to tell an attending that would have damaged me, but I could have damaged her, right? And so under those circumstances, I should have been willing to give up some of my privilege, right? I should have been willing to give up some of my powers for the sake of creating a more equal environment to allow her to express herself and maybe me get a better understanding of why our interactions were such. And then lastly, so when I took the medical directorship at Jersey Shore, I got a place down at Jersey Shore, beautiful place, Spring Lake, 3 blocks away from the beach, right? Again, when I first moved there in the Jersey Shore, I was pulled over 5 times in the first 2 months I was there by the police officers. And it got to a point to where I had to tell the police officers, put out an APB, talk to your chief, do something, but let them know that you have a Black neurosurgeon in Spring Lake now, right? And I am the only pediatric neurosurgeon on call in Ocean and Monmouth County. And one day it might be one of your kids during the summertime who's maybe hit by a car or something that I have to rush in and see. But the more times you pull me over, the more chances are there's going to be an encounter where I don't walk away from it, right? Now, about 2 months ago, I had a young lady with a eosinophilic granuloma that caused a complete collapse of her C6 disc space. She was 12 years old, a contortionist. And she started complaining of neck pain. She was seen by a pediatric orthopedic surgeon who got her x-rays and then sent her to me. And we ultimately had to do a corpectomy and a fusion. And, scouring the literature, I think it's the youngest, anterior corpectomy that was done. And I had to get special equipment flown out. I had to create a special, strut for her, create a special graft for her from a femoral strut. So it is by far the youngest case that's been done like this in the state of New Jersey, but it might be the youngest case documented in neurosurgery. When I write it up, I'll see. But I gave the family the option to go anywhere they wanted to go for this patient, and they elected to stay with us. And she's doing extremely well. The reason why I tell this story is her father was a fireman. And so when it was time for her to go back to school about 2 or 3 weeks ago, the fire department and the police department in Spring Lake threw her a parade, right? And for me, it was like poetic justice, because when I was getting pulled over, and all the other microaggressions I've experienced living in that community, I asked myself, like, why am I sacrificing so much for a community sometimes that feels like they don't want me there, right? But it made me feel good that my work was appreciated, that in some shape, form, or fashion, they do understand. And I know the police officers know who I am, right? Because they don't pull me over anymore, So yeah, that's it. Any questions? Oh, I think I went overboard, my apologies, but are there any questions that anyone might want to ask?
And Lawrence, Mark Swadan here. I know that Dr. Stieg had to run and Dr. Hoffman's running the OR as well. But first, I want to thank you. Unbelievably conscientious talk, very frank, honest in many levels. Many of us would view this as timely, but I'm sure most would also agree that it's quite delayed in reaching the level that it has in our profession and medicine in general. So thank you again for the earnestness. Any questions or comments for Lawrence?
Dr. Daniels, just this is Gary. I'm one of the neurosurgery residents. Just want to thank you for that, sharing your experience, and it's just constantly reminded about how much more work we have to do in our country. It reminds me of one of the greatest mentors I've had in all of residency was Christopher Newman. He was a fellow here at MSK last year, also African American. And when everything was happening over the summer last year, we were working together, and I was, went to him and expressed, how awful all of this is. And he's like, yeah, it is, but none of this is new. It's stuff we've been dealing with for years and years, and everyone's just realizing it now. And, I think for anyone, my family is being immigrants to this country and looking different from everyone else and having accents coming in, and for people of color and all these things, it's can often go unnoticed. I'm glad it's coming up to the forefront now, and I appreciate you sharing your experience.
I appreciate the opportunity. And, like I said, every single, one of my mentors was Dr. James Goodrich, and Dr. Goodrich was an, extremely wealthy individual, white, Christian male, right? But he came to neurosurgery late in life. He had, served time in the Vietnam War, and, came to neurosurgery because of an experience that he witnessed during the war with someone experienced a trephination, from a subdural hematoma that saved their life. And so he was driven, but, this concept of conforming was not something that he was known for. And it caused him a lot of strife during his residency training, right? And I think part of the reason why he took to me was because he recognized some of that same, experience, right? So I think that all of us, are susceptible to being, to falling victim of these group interactions. And as a result of that, all of us should be vested and interested in creating an environment where we can talk about it, where we can feel free and comfortable with talking about it. The only thing that I would say is those of us that are in a position of power, those of us that are responsible for training you, we have to be willing to take it on the chin a little bit, right? Because there's a power dynamic at play that, oftentimes is unfair.
Thank you again.
All right, fellas. Thank you. I have to run down and do a case now. I appreciate the opportunity to share, and if any of you guys have any questions or any concerns at any time, don't hesitate to get my information and reach out to me.
Thank you, Dr. Daniels, and all your effort you're putting into mentoring in medicine as well. It's fantastic.
You're welcome. Thank you, guys.
Thanks so much.
Take care.